Good morning, all. The Paris University welcomes you, sir, on this online platform. It is a great pleasure for me to introduce our speaker today, who is going to talk about amputation and its rehabilitation. Dr. Dhruv Dave is currently working as an associate professor in Ashok and Data Patel Institute of Physiotherapy under the Charotar University, Changa. He has completed BPD degree with the gold medal, MPT in rehabilitation, and PhD degree. He had also organized more than 450 community physiotherapy camps in and around 80 villages of Changa for awareness about the physiotherapy in society. He has also guided more than 50 research studies for the BPD, MPT, and the intern students. He was appointed as a local physiotherapist of the Indian cricket team in December 2005 by the Gujarat Cricket Association during third test match of India and Sri Lanka. So now I request you, sir, to take this online platform and share your knowledge with us. Do, sir, please.
Thank you very much, sir, for your kind words. Yes. Is it visible, sir? Yes. So, first of all, I would like to thank management of Charuset and my principal, sir, along with my other faculty members who have helped me to reach to this level to deliver a session on amputation and its rehabilitation. I also would like to thank management of Parul University and special thanks to principal Navjot Trivedi sir, as well as the principal of APC Gaurav Bhai sir. I also would like to thank my teachers and mentors who have imbibed the seeds of teaching in me since my undergraduates. And a special thanks to the authors and editors of the book, Principles and Practice of Physical Rehabilitation. This book has launched just 6 months back and doing very good so far as concerned with the rehabilitation in Indian context. Now, moving for the topic, talking about amputation. So, amputation is to be considered as either the acquired condition because of a result of a loss of limb. This happens usually because of any injury, trauma, disease, or maybe a surgical procedure, or it may be because of the congenital absence since birth, because of the deficiency of a limb. When an infant is born with a part or all of a limb, right? So we'll move towards the causes as what I have said. The number one cause which is very important is the various disease. When we are talking about disease, we are talking about either the vascular disease like peripheral vascular disease or type 2 diabetes, or because of the clotting of the blood, or because of the infection of the bone like osteomyelitis. So because of any kind of infection or disease process, the limb need to be cut. So that is one of the reason why the people have to go for amputation. The second important cause is what, because of the kind of road traffic accident, trauma, injury at various level happening, and this is one of the primary reason for the upper limb extremity amputation. The trauma is the reason, and in terms of surgery to remove the tumors from the bones, the tumors could be because of the benign reason or because of the malignant reason, then the part is to be removed. Now, talking about the data, The congenital amputation is only about 1%, while remaining 99% it's what is the acquired causes. From the acquired causes, the peripheral vascular disease is considering 64 percentage, and this is mainly happening with the elderly population. If we are talking about trauma, it is varying about 8%, and that is mainly happening with the road traffic accident. The malignancy is considered about 4% for amputation. The diabetes, which is one of the major and the silent killer across the globe, and which, if starting with the diabetic ulcer, the diabetic foot, diabetic ulcer, and then ultimately the individual need to have a loss of a limb. So diabetic gangrene and all also is one of the cause. A leading cause, about 21% is because of that the amputation is being happened. Talking about infection and the bone disease is comprising about 2%. Now, if we just classify and look at briefly about upper and lower limb amputation. So upper limb amputation, it could be the phalangeal amputation, only the interphalangeal disarticulation happens, wrist disarticulation. Then in below elbow amputation, the length of the stump is ultimately deciding. It could be long below elbow or medium or short below elbow amputation, elbow disarticulation, then above elbow amputation. Then if the shoulder is disarticulated from the glenohumeral joint, there is shoulder disarticulation, and in four-quartite disarticulation, it is the removal of the part of scapula, clavicle, and all the upper limb. Talking about the lower limb amputation, from Syme's amputation, the amputation is performed just above the ankle joint. Then for below knee amputation, again it is being divided into four subtypes: long below knee, medium below knee, short below knee, and very short below knee, depending on the length of the residual limb, the stump. It is being divided among those four subtypes. Knee disarticulation, the complete leg amputation and knee is disarticulated. Again, for the above knee amputation, it is being divided into the long, medium, and short above knee amputation, depending on the length of the residual limb. Hip disarticulation, where it is being implied to have the amputation through trochanter, femoral neck, and the hip is completely disarticulated. In hemipelvictomy, it's the hindquarter amputation, where complete hip along with the part of the pelvis is being removed. Now, when we are talking about the foot amputation, which we have talked about, Syme's amputation just above the ankle joint. For the transmetatarsal amputation, it is what through the metatarsal the amputation is being done. For Lisfranc amputation, it is a complete metatarsal amputation through tarsometatarsal joint, and in Chopard amputation, it's what the partial tarsal amputation through the mid-tarsal joint. So that is what, in brief, to brush up our knowledge in regards to the classification of the amputation. Talking about what kind of surgery is being performed, it could be myoplasty, myodesis, or the skin flap, and we'll go into the detail in later on part of our presentations. These are the major concerns in terms of the amputation rehabilitation. The factors that affecting the healing process are contaminated wounds, infected foot ulcers, the vascular problems, those are of very severe type. The uncontrolled diabetes, if the sugar level is not, even after having the amputation not been under control, then it will ultimately affect the healing process. Similarly, the renal disorders which are affecting the healing process, as well as the cardiac diseases are affecting the healing process. Major concern when we are talking about amputation and when we are taking the history, this is one of the very important point, which is about whether the individual is smoking or not. What so far the systematic reviews have said that smokers have always had a problem so far as concerned with the healing of the stump, healing of the remaining part of the body, and may need to undergo re-amputation in their future course of study. Now, when we are talking about the factors that is responsible for healing and delayed healing, the next important aspect is about the various dressings and dressing material types of dressings being used and its advantage and disadvantage. So various dressings are being used. Could it be soft dressings, sinkers, semi-rigid dressings to rigid dressings? And it all have its own advantage and disadvantage. When we are talking about soft dressing, the soft dressing is easily able to be applied to the residual limb. It's quite inexpensive, and in relation to accessibility for the incision, it is easily accessible. The problem with the soft dressing is that it will give very little edema control. And you and me, we all know in relation to amputation, what happens is that edema is what bound to happen to the residual limb. And if the stump is not come in its optimal size and shape, then that will ultimately delay the process of rehabilitation. Now, in relation to that delaying the process of rehabilitation, I mean by that our pre-prosthetic phase of rehabilitation as well as the prosthetic phase of rehabilitation, where we want to either introduce pylon, or that is a temporary prosthesis, or we want to introduce a permanent prosthesis, may it be patellar tendon bearing prosthesis or the prosthesis for the below elbow amputation and likewise. But because of the kind of edema which is what is present, ultimately hindering that process of rehabilitation. Now, another disadvantage with the soft dressing is that it will have a very minimal residual limb protection, and it requires frequent rewrapping, mean by the dressing is being applied, then after a period of time, as soon as the individual moves within bed, outside bed, and likewise, will require the frequent rewrapping of the dressing. Coming to the shrinkers part, it is again easily applied and inexpensive, but it is to be used only once the sutures are being removed, and naturally because of the kind of shrinking facility, the frequent changes are also required. For the semi-rigid dressing, it is very much beneficial in terms of edema control compared to our soft dressings and sinkers, and it protects the residual limb very much. Only the concern with the semi-rigid dressings it needs the frequent changing, and it does not provide any access to the incision. When we are talking about the rigid dressing, it is going to cost, but the concern is that it will provide excellent control over edema. It will give the enough protection to the residual limb and the control of the pain, which is what bound to happen with the phantom limb pain, that will be better handled when we are going to give rigid dressings. And that is the reason why, if you are now looking around the amputees, most of the surgeons, they would like to prefer to have the rigid dressings. Naturally, it has its own disadvantage, like no access to incision. As what I've said, it's going to cost your pocket slightly more, and requires naturally the proper training for its usage. So that's what we have talked about, the dressings, which are one of the important component. These dressings are very important for those who want to fly to the foreign countries, and where the wound healing and few other things are what being asked and recommended every now and then when the amputation and its rehabilitation is talked about. Now, when we are talking about rehabilitation, it is, you and maybe all know, it's about the team approach. It's not about the individual. It's not about the patient and physiotherapist. It's not about the surgeon and caregiver. It's what about all. It is about including physiatrist, surgeon, vocational counselor, vocational trainer, nurse, social worker, prosthetist, clinical psychologist, occupational therapist, and but naturally the physiotherapist, with the patient at the center of the rehabilitation process together. Now, when we are doing the post-surgical assessment, the various points we will be in need to take into consideration. Now, when we are talking about which points do we need to take into consideration, the first and foremost point which is necessary is about history. So what things we need to take in relation to assessment for history is about their demographics, their family history, and socio-economical status, what is there that is need to be assessed. And along with that, it need to be assessed about the pre-amputation status, mean by prior to undergoing that amputation surgery, what the individual was doing in relation to his work, in relation to his activities of daily living, and in relation to the leisure activity. These things would be helpful when we start doing rehabilitation of that individual in the future context, and to have the acceptance of the prosthesis as well as the total rehabilitation program. It is very much necessary that we should know about the individual's pre-amputation status in relation to their activities of daily living, their work culture, and their leisure activities, and likewise. In terms of which are the systems those need to be assessed and reviewed are about the vital signs, the pain, the medications, if any complication that has happened or not, about the cause of amputation, because if the cause of amputation is peripheral vascular disease and smoking is the history, then the smoking cessation is one of the role in relation to clinical psychologist. And likewise, if it is diabetes, which is what is the reason, then we need to take care about the control of sugar from diabetologist point of view, as well as through exercise, diet from dietitian perspective, and likewise, if the cause is trauma, injury, then the post-traumatic depression and few other things are what bound to happen, which we need to take into consideration, along with the any kind of coexisting medical conditions are there or not. In terms of assessment of skin, what we need to assess is about the scar, whether the scar is healed or adherent or flat. What about the moisture of the skin, whether the skin is dry or moisture or scaly. About the sensation, whether the sensation the residual limb are absent or diminished or hyperesthesia. About the graft, where is the graft from where the skin is taken, so whether that graft is healed or not, any kind of dermatological changes that might have happened, like psoriasis and eczema is what one of the major concern in relation to the skin and skin related changes, because of the kind of nutritional status the individual has. In terms of residual limb length and shape, as what I have mentioned in the classification, according to the length of the residual limb, the individual's amputation is being classified. and it is not like that the shorter the residual limb, the better it would be, or longer the residual limb, better it would be. The limb length, the residual limb length, how it is to be measured, we'll see in few of the next slides. But the concern is that the optimal length of the residual limb is necessary along with the shape. So that is what our major area and concern. The shape should be cylindrical, conical, or bulbous, and what it is, or whether the dog ear type of appearance is over the adapter roll, or specific circumferential measures need to be taken into consideration. When we are talking about the various system assessment, for motor system to be assessed, it's what about for the affected side, the remaining joints, range of motion, and the strength of the muscles. Along with that, the strength of, if we are talking about lower extremity, the upper extremity strength need to be as like the superhumans, because it may be possible that the individual need to use the energy from the upper extremity or vice versa, where the energy demand of the body is going to be higher. So for that, the reason why we need to assess the strength and the range for the motor examination. When we are talking about the neurological system, it's what about pain, whether the different types of pain sensation, and along with that, the neuropathy that might have developed, the cognitive status of the individual, whether the individual is confused or oriented, alert, and likewise, and the emotional status of the individual, whether the individual is ready to accept the body and body image, which is one of the major concern when we are handling the clients in the prosthetic and pre-prosthetic stage, where they are not ready to accept themselves after amputation. When we are talking about the cardiovascular assessment, it's what about their pulses. When the peripheral vascular disease is the cause, we need to be very sure about the pulses at the distal part of the limb. Along with that, the color of the residual stump, and about the pain and the trophic changes, and the aerobic capacity of the individual need to be assessed. Now, why aerobic capacity is because of the loss of the power of a limb or more is ultimately causing the increase in the physiological cost index. And as the increase in the physiological cost index happens, that's what going to challenge the individual cardiovascularly. And that is the reason why the aerobic capacity of the individual need to be assessed. And these things are to be held in our pre-prosthetic as well as prosthetic state, when we are going to analyze the individual after 3 months, 6 months, and 1 year follow-up. So how much the individual has improved or deteriorated in relation to their cardiovascular capacity would be a greater point in concern. When we are talking about the functional status, the prior abilities I have already said, and along with that, the basic as well as the instrumental activities of daily living need to be assessed with various outcome measures are available, may it be FIM, may it be Barker index, or many other index outcome measures are available, which would be used for analyzing the functional status of the individual. When we are talking about the quality of life, the quality of life is one of the major and in thing so far as concerned with physiotherapy and most of the disease. And ultimate aim of any of the individual is to have a good quality of life. even if whether few years are only remain, still they need to have a good quality of life. Along with that, the psychological status, which one need to assess and need to know about which are the barriers or facilitators which are ultimately affecting in relation to the motivation of the individual, right? So these are the few points which I have taken into consideration. Now moving on to about the stages of physiotherapy management. So when we want to ultimately help reach the goals of the individual in amputation rehabilitation, it's very much necessary that one need to work in team, but along with the team, it's what strategically one need to work. One need to help improve the wound healing and the stump care, which is very important. And unless and until the wound is being held, the stump residual limb comes into its appropriate shape and size, it's not possible for the rehabilitation team experts to start doing any kind of further process in relation to start using a pylon or even any other processes. Another concern is about activities of daily living, which needed to be restored and help patient to reach the maximum independence. And if you know the way the kind of advancement in the processes, field of mechanical engineering, field of health science, field of artificial intelligence, computer, and likewise the way it is happening, the way the processes are coming, the individual can do the kind of tasks in relation to their independence as much as possible. If they want to be part of a marathon run, they can be. If they want to be a part in any kind of Paralympics, they can be. If they want to be a part of mountain climbing team, they can be. So it's always possible, provided they are very sure about what kind of activities of daily living they want to achieve and how to reach those maximum independence. The exercise that need to be done are targeting the strength, the endurance, and the control, coordination is very much necessary. And for that reason, the pre-prosthetic and prosthetic stage is very important. Along with that, one of the major concerns which many of our clients have are about the pain interference. So the pain management, including post-operative and the phantom pain, needed to be addressed very well. Emotional support is very much necessary because the individual has lost a part of limb, and which was there, and because of that, the limb that has been lost could be a dominant limb. Could be so far as concerned upper extremity, or it could be a kind of if we are talking about lower extremity, then that will ultimately affect the individual in relation to his mobility in surrounding, in society, and likewise. So that's one of the major concerns, where the emotional support from the friends and family members, especially in grieving period, for providing the readjustment to the newly normal life, right? Along with that, it's what about the assistive devices usage. If the individual is going to be wheelchair bound, then how to propel the wheelchair for the initial phase. If the individual is going to use a walker, or individual is going to use any kind of crutches, so how to use that needs to be trained. The nutritional counseling, as what I've said, is very important, especially either of the case. If it is non-traumatic, then we need to identify whether it is diabetes or vascular causes, and likewise, and dietary modifications. If it is the traumatic cause, then the kind of nutritional supplement should be such so that the wound healing need to be as much faster as possible. For vocational counseling, there our role is very much major. And as what I've said, in our initial screening process, it is very much necessary that we need to know about our pre-amputate status of the individual for vocation, and after amputation, what kind of activities the individual would like to do in terms of their interest, aptitude, ability, and likewise. And accordingly, if the individual is being counseled vocationally, that would be a great help. Along with that, the vocational counselor and vocational trainer with physiotherapists and occupational therapists could help the individual in terms of getting the benefits of permanent physical impairment over a period of year or so, once everything is settled down. So that's how this vocational counseling would be helpful. In terms of adapting home environment, it is one of the major concern, because when the house is built up, it was not built up the way about the accommodation with the assistive device, with the processes and likewise. So accordingly, if needed, the modification in the home environment would help in ease of function, safety and accessibility and mobility. Along with that, this I always emphasize for all of my fellow friends as well as students, that the patient education, the family caregivers education is very, very important. Whether we are talking about amputation, we are talking about diabetes or any other topic. Why? Because unless and until we educate our clients, unless and until we educate their caregivers, it's what naturally that they may go either way. Their expectations are either going to be too high or their expectations are going to be too low. So to overcome that problems and issues and concerns, it is very much necessary that we will educate our patient and the family members in relation to the particular condition, what is expected, how the role of the total rehab team, and how gradually each one of us will work so that we can have the optimum results from the individual. When in very few cases the pre-operative period for us would be available, where we do the assessment in relation to their physical, social and psychological status, in relation to the treatment program which is going to be followed would be a breathing exercise. Again, it has its importance. Why? Because that will ultimately reduce and minimize the kind of complications which are bound to happen after any kind of surgery. To overcome that, it is very much necessary that the breathing will need to be emphasized upon. Along with that, the strengthening exercise, as what I have mentioned, that if it is the lower limb that gets affected, the strength of the upper limb, the shoulder extensors and the adductors, as well as the elbow extensors and the hand grip muscles, with the strength of the abdominals need to be emphasized, because this will ultimately help the individual to have the energy from one area and dissipate it to the other area, to move forward to do some kind of work, whether the individual is a below knee amputation, above knee amputation, or any kind of such. The mobilizing exercise are very much necessary. But these exercise in the initial phase are necessary to allow not to have any kind of tightness to be developed. The tightness, those are what going to be developed in the mainly the two joint muscles, the hip flexors as well as the knee flexors. And that's what, where if we are in a position to put our clients in prone position every day for few hours, that will ultimately overcoming the problems that's going to happen there with the hip, and along with that the kind of problem that's going to happen with that of the knee. The mid mobility is where the part of OD will come into picture, where in the initial phase the individual need to move in bed, do the bedbound activities, move from couch, blink to wheelchair, to chair, to the low stool. So all this kind of bit mobility is very important. The rolling, prone, supine, sideways, transfer activity, this all would be very important. Doing wheelie on wheelchair, taking the wheelchair and to be on the red two wheel, this all will be help the individual to be accommodative if the individual is going to be wheelchair bound so far as concerned with community and can move around with the wheelchair within the community. In pre-prosthetic phase, it's very much necessary that the firm mattress as well as the rope ladder would be helpful. The rope ladder would be helpful for the individual to take from lying to that of sitting, and about the firm mattress would be helpful so that it is not going to slip at all. Along with that, in the pre-prosthetic phase, when the pain is what bound to happen more, the analgesic role is very important in relation to combating the phantom limb pain. The aims which are what going to be are about post-operative complications, prevent the deformities, control the stump edema, maintaining the strength of the whole body, general mobility, transfer activity, re-educating the walking, functional independence, and phantom pain. We'll go into each is about the brisk foot exercise and breathing exercise. For prevention of deformity, it is very much necessary that one need to stretch the quadriceps for a below knee amputation, and for the hip extensors and adductors for a short above knee amputation, and for hip extensors and abductors in long below knee amputation. This will be important once the drains are out within 2-3 days, and this would be associated along with that of the free exercise and the resisted exercise later on part of life. In terms of controlling the stump edema, the things which are very much necessary is about doing the contraction of the muscles of the residual limb by the muscles, and the contraction need to be either fast or slow and sustained. So by two way we are in a position to help in ultimately taking the fluids out from the particular area towards the central pathways. In this, it is very much necessary the role of crepe bandage and the compression garments. This compression socks and the crepe bandage would help ultimately in relation to controlling the stump edema, taking the residual limb to its original shape and size. And if the end part of the stump, the wound that is not yet healed, then it is very much necessary. Or if the breakage that might have happened and because of that the infection has happened, it is necessary that one may need to even go for UVR with the E4 dosage. Right? Talking about the strength protocol, the strengthening is very much necessary. If the individual be in lying, let it be in lying. If the individual can do it in sitting, do it in sitting. If the individual can do it with the wheelchair, with the various multi-gene exercisers, and likewise with the weights, with the therabands, with the theratics, all this is to be used in relation to strengthening the normal. And as what I have said, those normal need to be super normal. need to be superhuman. And the things which are remaining, which are what has affected, would be taken into consideration. May it be, if we are talking about below knee, that the quadricep need to be targeted by various positions, right? And to the unaffected side, as what I have mentioned, it's what about the anti-gravity muscles that need to be targeted, with the lying, with the sitting, and even with the resistance. This exercise would be very much necessary, along with the stump exercise. As soon as the drains are out, the knee is to be straightened against the resistance. In above knee amputation, the prone lying and the leg lifting is necessary against the resistance. And the hip extensors can be strengthened using either the weight or the weight and play circuit, or even the manual resistance and the mechanical resistance. The major concern that's bound to happen after in pre-prosthetic phase with the amputees is about the balance. Now, why the balance is the issue is for our second year physiotherapy, the way the biomechanics has changed, the way our center of gravity and the line of gravity has changed, the way our base of support has changed, and that is ultimately affecting our balance, whether the balance is a static balance or dynamic balance, and likewise, and it will ultimately affect the transfer of the individual from bed to chair to wheelchair to move around in parallel bar, in standing frame, and ultimately start walking, moving the line of gravity within the base of support, and likewise. So the balance is one of the major concern, and that is the reason why the individual's balance is to be assessed, and then after the training through tapping in all direction is to be given. If the individual's sitting balance is the concern, then that is to be, and if it is the standing balance which the prosthesis, temporary prosthesis on, then accordingly the items of the work balance are to be used as part of not just the assessment, but even for the treatment purpose, right? And once that is to be achieved, then gradual use of whole board for the advanced balance work could be possible. In relation to once the individual is able to have the balance in sitting and standing, then naturally the next course of action, as with about our normal growth and development, about walking. So the walking that is to be made with the parallel bars and with the walking frame and the crutches. This walking will ultimately boost up the confidence of the patient. This walking will help the individual to move in and around the home, and that would be easier and faster for them to start using the processes all in the rooms, and not only just be wheelchair bound. In relation to functional independence, it is very much for us to not only just assess but try to make the individual functionally independent in line with the occupational therapist. Help them in relation to with their dressing difficulties, transfer to the bathroom and washroom. Help them in relation to their activities in relation to eating, cooking, dressing, and try to help them and encourage them to be as much independent as possible. This will ultimately help them to reach to their future aims of as much independence as possible. And that is the reason why the continuous motivation, the continuous encouragement is necessary for the independence. For phantom pain sensation, this is what again a part of patient education, family education, where we need to make them understand that the part might have amputated, but still the same part which has been cut, its impression is being there in the brain. So brain is still yet not ready to accept that the part has been removed, the part has been amputated, and that's why the continuous pain is what bound to happen. Yeah. which are the contractures that need to be prevented is about the hip and knee flexion contracture, and that is what is to be done as what it has been mentioned. This is particularly the kind of stage, post-operative stage, where the individual is hospitalized. So what kind of exercise that is to be done on day 1, 2, 3. And now this is one of the major important concern when we are talking about the residual length of the stump. So when we are talking about the transtibial, it is to be measured from the medial tibial plateau, from that to the end of the bone until the end of the skin. That is to be measured in relation to the residual limb length of the transtibial amputation. Starting at the medial tibial plateau and taken every 2 to 3 inches in relation to the circumference measurement, which will make us know about what kind of circumference the individual has, and accordingly the socket is to be given. So for that measurement, the length and the measurement is to be done in relation to transtibial. For transfemoral, you know that the 2 bony landmarks for the transfemoral, number 1 is ischial tuberosity, and if the ischial tuberosity is not able to be palpated, the greater trochanter is to be used from there to the end of the bone until the end of the skin, which is to be measured in relation to the length of the residual limb for the transfemoral amputation. When we are talking about the circumferential measurement, starting again from either of the bony prominency, could be ischial tuberosity or that of the greater trochanter, and every 3 to 4 inch the circumference is to be measured, and accordingly it is to be decided that whether the stump is edematous, bulbous, dog eye ear appearance, or the stump residual limb has reached to the optimal shape and size. What kind of gait abnormalities, which is our area of concern when we are talking about the transtibial and transfemoral amputation. It could be either excessive knee flexion to insufficient knee flexion, or the knee flexion could be delayed, or the lateral shift of the trunk in relation to transtibial amputation, or the prosthesis may get shifted laterally, or the foot gets rotated. So those are the gait deviations with the transtibial prosthesis may happen. For transfemoral, it could be an abducted pattern, or the rotation of the foot with the circumduction or uneven step length, uneven timing of the prosthesis, and even the prosthesis may drop off. When we are talking about the difference between the sage foot and the Jaipur foot, which are what the terminal devices being used for the prosthetic fitting, the advantage of sage foot over the Jaipur foot would be the kind of sophistication it has. The solid ankle cushion heel require a closed footwear for the protection purpose, while Jaipur foot could be used just like that. Squatting and cross leg sitting would be possible with the Jaipur foot. The subtalar joint movement would be possible with the Jaipur foot, and so that especially in the rural area where we are located or you are located, on the uneven ground and surfaces, the foot which is if used of Jaipur kind would be helpful in relation to accommodating the uneven surfaces. In the Indian rituals, the kind of cultural preferences, barefoot walking is one of the major events considered, especially at home, especially at religious places and likewise, and that is the reason why the acceptance of using the Jaipur foot is much more over the sage foot. when we are talking about the pressure tolerant areas and the pressure sensitive areas. The pressure tolerant areas are the patellar tendon, the flares of the tibial condyle, the areas above the femoral condyles, shaft of tibia, popliteal fossa, and the distal end of the residual limb. And the pressure sensitive areas is the head of fibula along with the peroneal nerve. So the peroneal nerve entrapment may happen after using the prosthesis, distal end of the fibula and tibia, and the sharp crest of tibia. These are the pressure sensitive areas, and that's where we need to see to it about providing the cushion effects in the PDB socket. Right. So here in figure, the areas have been shown. This is about the transtibial processes with the PDB socket. The quadrilateral versus the ischial containment socket, and the suspension mechanism, that is for the transfemoral processes. It could be the suction valve mechanism or the total elastic suspension, which is not being supported. Now, moving to the upper limb processes. Now, when we are talking about the upper limb processes, it is very much necessary that the upper limb processes, the terminal device could be hand or could be hook. When it is to be hand, the hand could be either passive just for the cosmetic purpose, or the hand could be active hands where they are being operated by the cables or by the myoelectric hands. When the hooks are being used, again the hooks are being subdivided into the cable operated and the myoelectric operated. With the cable operated voluntary opening and the closing mechanism available with the upper limb processes. So this is what is the myoelectric transradial processes, with the hand available with the voluntary opening and closing in the below elbow processes. The self suspension transradial socket, this is basically being used with that of the cosmetic purpose for the below elbow processes. The major concern with the wearing and removing the processes of the upper limb. So it is very much necessary the steps that need to be followed in relation to applying a sock or a liner, then inserting the residual limb in the socket, and then ultimately inserting the sound limb through the axillary loop. And by doing this movement of the scapula or of the shoulder will ultimately produce the movement of the hand of voluntary opening and closing, and that is how this figure of 8 harness would be helpful. When we are talking about myoelectric control, it's what about wearing cordon knit and then taking care of the proximal margins, especially in the antecubital fossa, then applying the socket, and then pulling the distal end through a hole in the socket, and thereby drawing the superficial tissue of the forearm that's going to completely into the socket. And for removing the part, it is very much necessary that the distal part of the prosthesis is gently tugged until it is off the forearm. And that is how the upper limb processes and the lower limb processes all are being used. And that is what in nutshell about the amputation and its rehabilitation. I know that the time is the concern for us, and I have tried to cover it up about processes, what are the team members, what and how the rehabilitation is to be ultimately assessed, and that is what is about the amputation and its rehabilitation Sorry for the in between technical error, and I beg your pardon for that. Time and again, I would like to thank Parul University, Nilesh sir, and the technical supporting staff for organizing such a nice event and providing the support for the individual like me who is not technically that great sound for delivering the sessions. So thank you very much once again from the bottom of my heart. And if any other things, I'm always ready to help you out. Yes, sir.
Yes. Thank you very much, sir, for this knowledgeable presentation. You have enlightened many things about the amputation and the rehabilitation. You have also focused many key points of rehabilitation, which will be really helpful for our future physiotherapists. Am I audible, sir? Now,
Sir, I'm not able to get your sound.
now can I? Now, are you able to hear? Sir?
Yes, you are.
Yes, thank you very much, sir. Dhruv, sir, thank you very much for your knowledgeable presentation. You have enlightened many things in this amputation and rehabilitation. You have also focused the key points so that our future physiotherapists will be helpful for doing the rehabilitation in amputation. Thank you very much. We again say thank you to you all on behalf of the Parul Institute of Physiotherapy and the Parul University, sir. Thank you very much, sir.